Good morning and good afternoon, everyone. I'm Agnes Lee, and welcome to our CAN Vector National Thrombosis Seminars. This is the last of our series for this academic year, so I'm really excited to have two outstanding speakers joining us today, and we will be restarting the seminar series in September. As many of you know who've tuned in before, this is a monthly seminar series, and it is held throughout the academic year, and it's hosted by CAN Vector. This is recorded, so if you didn't have time to sort of join us live today, you can certainly go to the CAN Vector website and watch the video again. And if you like the pearls that are going to be shared during these seminars, by all means, you can certainly go back to the videos again to watch. The seminar series is approved by the Royal College for roll count points, and you do need to make sure you submit your points after the end of the seminar today, and we will be sending you a link to ask for feedback, and then you'll be able to collect your points. So I just want to thank the planning committee who have helped us put the various sessions together. And for today's presentation, we're going to be looking at testing for venous thrombosis. How can D-dimer be your friend? And we're joined by Dr. Kirsten DeWitt and Dr. Rita Selby, two outstanding, fantastic speakers who know more about this area than probably many of us combined. So I can't think of better speakers to review this. So the learning objectives today is basically to describe various clinical decision rules available to diagnose venous thromboembolism, understand how D-dimer can be helpful in decision making and perhaps sometimes not helpful, and then recognize the pitfalls associated with this diagnostic strategy and how to overcome these. So after the presentation, there will be a 15-minute Q&A session. You can submit your questions anytime during the talks using the Q&A. Please don't use the chat function because that won't be widely available to everybody. So please put your questions in Q&A, and we will address them at the end of the presentation. And so I'm going to introduce both speakers before the talk today, because both of them are actually going to be doing a combined talk, so they'll be going back and forth. And so Dr. Kirsten DeWitt has 2 university appointments. She is an associate professor in the Department of Emergency Medicine at Queen's University, and she's also associate professor at the Department of Medicine and Department of Health Research Methods, Evidence, and Impact at McMaster University. She is trained in internal medicine, emergency medicine, and research from the UK, and she completed a thrombosis fellowship in Ottawa in 2013. Since then, she has worked in both emergency medicine and thrombosis, and she leads a research program which focuses on the diagnosis of bleeding and clotting disorders in the emergency department, and it's funded by CIHR and PSI. Dr. Selby is a hematologist specializing in thrombosis and hemostasis, and she is the medical director for 2 regional reference coagulation laboratories at the University Health Network and Sunnybrook Health Sciences Center. She's an associate professor in the Department of Laboratory Medicine and Medicine at the University of Toronto. Her research interests include coagulation laboratory quality assurance, appropriate utilization of laboratory testing, and pragmatic clinical trials in anticoagulation and thromboembolism in trauma. She is the co-chair of the Test Review and Utilization Committee and an advisor to the Laboratories and Genetics Branch of the Ontario Ministry of Health. Finally, she is the editor and author of the popular coagulation handbook, Bloody Easy, Coagulation Simplified, that's used for coagulation education across Canada. If you're not familiar with this book, I highly recommend you get this. It is valued by trainees, physicians, clinicians all over. And it makes coagulation approach very, very easy to understand and practical. She's developed and taught mandatory coagulation laboratory curriculum for the University of Toronto for hematology and hematopathology residency programs since 2009. So again, like I said earlier, I can't think of more suitable speakers to lead us through the diagnosis of thrombosis today. So Dr. DeWitt and Dr. Selby, thank you very much for joining us. And I forgot, there are no disclosures for either of our speakers today.
Thanks so much for having myself, Kirsten DeWitt, and Dr. Rita Selby present today on D-dimer in diagnosing venous thromboembolism. I'm an emergency physician and a thrombosis physician. Dr. Selby is a coagulation laboratory hematologist, and it's a pleasure for us to come and present. So I'd like to start with a case. When I work in the emergency department, I'm frequently asked by my colleagues about the best tests for pulmonary embolism. And this is a typical case. A 74-year-old lady comes in with new difficulties breathing, palpitations, and maybe some dizziness when she walks up the stairs. And the emergency physician is happy that there's no cardiac issue going on, but they've decided they need to test for pulmonary embolism. And they often come to me saying, you know, can I use D-dimer to rule out PE here, or should I just organize the CT scan? And there are obviously pros and cons to doing both. On one hand, the CT scan will tell you, yes, there's a pulmonary embolism, or no, there's not, and it's one single step. But it does take more time than ordering D-dimer and getting the results. And it exposes the patient to radiation, to contrast dye, costs the hospital money, and importantly, more CT scans lead to more diagnosis of inconsequential pulmonary embolism. So we're going to start off by reviewing what D-dimer is.
Thank you, Kirsten. So a little bit of a recap about D-dimer biochemistry. So as you all know, when thrombin is generated, it cleaves fibrinogen to form soluble fibrin monomers that then polymerize to form insoluble fibrin polymers. Thrombin also activates factor 13 that then cross-links these fibers. And cross-linked fibrin is the scaffolding that makes up the thrombus. TPA converts plasminogen to plasmin, which then starts fibrinolysis. And D-dimer basically is the smallest fragment, breakdown fragment of cross-linked fibrin. So it's a dimer of 2 D fragments. However, patient plasma is a minestrone soup of both D-dimer fragment, but also breakdown products of all of these soluble and insoluble fibrin monomers and polymers. And so the assays actually that are developed have monoclonal antibodies that have been raised not just against antigen D-dimer, but they variably cross-react with all of these other high and low molecular weight fibrin and fibrinogen degradation products.
So usually when I'm asked about the right next step for testing for pulmonary embolism, I ask the physician, have they calculated the Wells score? So I've put a clip here of the Wells score that you would find on MD Calc. And the critical number to remember is 4. So if the patient scores 4 points or less on the Wells score, then there are 3 options for using D-dimer to exclude pulmonary embolism. The first option would be to use the recommended manufacturer cutoff for D-dimer to decide if it's positive or negative. The second option would be to use age-adjusted D-dimer, where if the patient's over the age of 50, the new threshold would be their age times 10. And the last option would be clinical probability adjusted D-dimer, where in this case, we would use a threshold of 1,000 to decide positive or negative D-dimer. Some people have a little bit of difficulty remembering the Wells score and they think it takes a little bit too much time to calculate. So then this might be a better score for them. This is the years score for pulmonary embolism, which includes D-dimer. So there are only 3 of the Wells items to remember: signs and symptoms of deep vein thrombosis, hemoptysis or pulmonary embolism is the most likely diagnosis. If there are no years items, then you can use the threshold of 1,000 for D-dimer. If there are one or more of the years items, then the threshold is reduced to 500 to rule out pulmonary embolism. So the confusing thing about this is these rules are somewhat contradictory, and it's quite possible that one patient would either receive a CT scan or not, depending which rule you chose to use. So I have a summary here of the different rules involved in adjusting D-dimer. So these are the main validation studies, and actually the only prospective studies that exist evaluating these rules. The PEGD and the 4D studies evaluated clinical probability adjusted D-dimer here in Canada. PEGD was for pulmonary embolism. The 4D study was for deep vein thrombosis diagnosis. The years study was validated in the Netherlands, and the Adjust PE study validated age-adjusted D-dimer in 4 European countries. The important difference between the validation of each of these rules is that the prevalence of pulmonary embolism or deep vein thrombosis in the case of 4D varied considerably from country to country. So the lowest prevalence of pulmonary embolism was here in Canada with the PEGD study. And then the highest prevalence was the validation of the age-adjusted D-dimer in Europe, where the prevalence was actually almost 3 times that of Canada. This is a meta-analysis that we published last year, and it's comparing the prevalence of pulmonary embolism amongst patients tested for PE in the emergency department in North America, which is the set of values that you see within the red circle, and Europe. And you can see that in North America, the prevalence is much lower in studies that followed a systematic evidence-based approach to diagnosing and ruling out pulmonary embolism. It's much higher in Europe. With that, we would expect that in Canada and in the US, we would actually get the biggest bang for our buck with D-dimer and clinical probability, because we're going to be able to rule out pulmonary embolism without scanning in a much greater proportion than we can in Europe. But the interesting thing we found was that even though these are all using standard tests, Welsh score and D-dimer or Geneva score and D-dimer, we found even when you compare the people who have diagnostic imaging, there's a lower yield of diagnostic imaging in North America compared to Europe. So it seems that the patients we're testing here are qualitatively different to those who are being tested in Europe. So that just goes to show that probably these scores would actually have greater value here in Canada than they do in European countries. And although it seemed that the efficiency or the proportion of patients who actually required imaging in these validation studies varies quite significantly from the PEGD in Canada, where only 1/3 required imaging, to Adjust PE in Europe, where 65% required imaging. It's very likely that if we use age-adjusted D-dimer here in Canada, we'd actually be able to reduce our scanning right down to something between 30 and 40%. These are the false negative rates for the entire populations who were studied in these studies. And you can see the false negative rates are very low. So they did show that these approaches are safe. They also have in common that many of the people who were diagnosed with pulmonary embolism or deep vein thrombosis and follow-up actually had negative scanning at their original assessment. And the last row here is a representation of the number of people in each study who actually had their management changed because there was a higher D-dimer threshold used. And that was obviously a much smaller proportion of the entire population of the study. So for example, for PEGD, it's only about 350 patients had a change in their management to rule out PE compared to a standard D-dimer approach. For the 4D study, there were about 300 patients. And for the Adjust PE study, 331 patients had a change to their management. The year study was a bit different because they had a completely different assessment for pulmonary embolism. So of those who were negative for PE without requiring a scan by the years items, then 4 out of 1,300 or so patients with no years items were subsequently diagnosed with VTE, and 3 out of 323 with years items were subsequently diagnosed with VTE. And I just list the names of the D-dimer assays here so that you can see there was quite the spread of D-dimer assays that came up with a false negative result. So how should we approach testing in the emergency or on the internal medicine ward when someone's just been admitted? We know that the clinical probability adjusted D-dimer will be more efficient in reducing scanning in young people, and age-adjusted D-dimer will be more efficient in reducing scanning in older patients. So can we mix and match? You can if you want to, but it's really important you remember not to mix these scores up and you're very clear about the testing process that you're using. And if you choose to mix and match like this, then you're probably going to raise your false negative rate up a little bit higher for maximum efficiency. And then this year, there was a study published where they looked to see, could we actually get a new score that would dictate which of these approaches patients should have? What would be the most efficient way to exclude PE without scanning? So this was quite a complicated score that was derived on data that had previously been collected for other studies in Europe. And they determined that depending on the patient's score, you could either stop testing for pulmonary embolism, you could use clinical probability adjusted D-dimer, or you could use age-adjusted D-dimer or no D-dimer. Because this is quite a complex score, I think this would be something that would have to be embedded in the EMR or else be in some sort of computerized model. So we previously interviewed a number of emergency physicians across Canada to get an idea of how exactly they normally test for pulmonary embolism. And these are some of the comments they made which are pertinent to using some of these rules.
Taking the time to sort of look up the tool and what have you, because obviously can't remember everything. What point value goes with what item and what have you. So like sitting down and looking at it or looking it up or what have you. It might only take a minute, but it's a minute where you could have been seeing the next patient or finishing up your charting or whatever.
You know, your grandmother didn't look at a recipe card to make your favorite dishes by memory, right? She gave it to you and you wrote it down. You do it a few times and you do it often enough, you stop looking at the recipe card. You'd also tinker with the recipe card to add a little butter or mint or something. You tinker with it a little bit to make it suit you better.
2 quotes just exemplifying that it takes time to apply these rules properly, and we have to be really careful not to modify the rules to suit us. So time and time again, I hear emergency physicians say, well, I don't use the Wells score or the Geneva score, I just use Gestalt. In this big survey study that we did, we found that by far and away the most common estimate of clinical probability was Gestalt. There's good reason not to use Gestalt. So we found there was a very close relationship between using your Gestalt and deciding that you wouldn't do a D-dimer and you would simply order a CT pulmonary angio instead, with the suggestion that Gestalt always seemed to be high.
Because you already know the patient's getting a CT. You don't need a decision rule for that.
But I think that in this patient, because I am so concerned about PE, that I don't think I would apply any of the rules as mentioned. I can apply the PERC. I can probably apply the Wells criteria. But to be honest, I'm so concerned that I would move straight forward, straight ahead to the CT.
And this is another common reason that I see for physicians not using D-dimer. So they say, well, I can't apply the Wells rule or D-dimer to this particular patient. So this is our same patient, but in this case, I've changed her to being somebody who has cancer. And I hear time and time again physicians saying, if there's cancer, I just get the CT scan because I don't think the D-dimer will be normal or because I think they're at high risk, which is clearly not the case because cancer is only 1 point in the Wells score. So there's really no reason that we can't use D-dimer and Wells score. In this case, the patient's 94, she's not 74. And again, physicians often use that as an excuse to say, well, I'm not going to use D-dimer because I don't even think that I can age adjust it. But you won't know until you've measured it. patients who've got a previous history of DVT or pulmonary embolism, I see that physicians often tend to overestimate their probability and think this person's very high risk of PE, so I'm not going to perform a D-dimer. But there's only 1.5 points assigned on the Wells score for a previous history. And then another very common reason for not using clinical probability in D-dimer is when the patient is hemodynamically unstable. In that case, I often hear physicians say the patient's too high risk to use D-dimer. But by that, they often mean that the patient is high risk of death and not necessarily high risk of having pulmonary embolism, because they don't actually know what's wrong with the patient at that time. And I would argue if you order D-dimer when you order all of your blood work, then you'll have that result back in time, at the same time that you've been able to stabilize the patient, because we don't really want to send a patient to the CT scan if they don't have to, particularly if they're at risk of hemodynamic instability.
The answer is actually he is excluded. He is overtly excluded. He's had a previous PE, which is a point, but he has a known disease like his factor V Leiden. He is just out, like he is completely out of all of those derivation studies. He is not even included. I don't even know whether the original derivation studies, because his first one when he was 13 or something like that, I don't even know whether those studies included kids that young. They probably did. They probably excluded them.
Just another example, this physician doesn't want to use the Wells score because the patient has factor V Leiden and because he had a PE at the age of 13, which seems a little random, but that was their rationale. And then this is the last excuse that I see a lot, and that is that the Wells rule and D-dimer was created for somebody else, but it wasn't created for me. So I see thrombosis physicians and hematologists saying, yeah, you know, it's really for internists and emergency physicians. I don't use it. And then I see the internists, they tell me, well, all my patients are high risk, so I don't use it. It's really for the emergency physicians. And the emergency physicians sometimes tell me, you know what, it's not really for me to use. It's for teaching medical students so they understand what the risks are for pulmonary embolism. And that's something I think we all have to address and take responsibility for, because the Wells score is good no matter your expertise or your background. As long as it's the patient who's coming to hospital from home, then it has been validated to use with D-dimer. So what happened to her patient? Well, of course, she only scored 1.5 points on the Wells score. And when her D-dimer came back, it was only 467. So she didn't need a CT scan. So now I'm going to hand over to Dr. Selby, and we're just going to change over screens.
Thank you, Kirsten. So you've heard Kirsten cover all these various thresholds, classical thresholds, age-adjusted thresholds. And you might be wondering, like, how are these exclusion thresholds even established? So it's interesting that D-dimer assays actually come in 2 flavors. So one kind of assay, basically on the product insert or on the package insert, says that the D-dimer assay is suitable for exclusion of VTE. And in those instances, the manufacturer actually has to do a traditional management study. They have to enroll patients, use their D-dimer plus a clinical probability assessment at a minimum of 3 study sites. The sample size has to be enough that they have a significant number of consecutive eligible outpatients where the prevalence of DVTP is over 10%. And they have to compare their D-dimer assay to proven VTE via imaging, as well as 3-month follow-up to assess for recurrent VTE. And they have to have established cutoffs for a high sensitivity and high negative predictive value. But if your lab assay says aid in the diagnosis of VTE cutoff, that manufacturer actually does not do a formal management study like this manufacturer has done. All this manufacturer has to do is collect outpatient samples at 3 study sites with a prevalence of greater than 10% and compare their D-dimer to the predicate D-dimer method, which was established using the management study with a cutoff for NPV. So I don't know about you, but I think that the evidence bar for the first assay and for the subsequent group of assays are significantly different. So something that has been validated using a management study directly, whereas something that has been compared to a D-dimer that was developed, the exclusion threshold was developed using a management study. So those are the two different levels that come with different assays based on the evidence that the manufacturer has gathered. So are D-dimer assays interchangeable? I showed you a little bit about the biochemistry and the fact that the monoclonal antibodies are diverse and they cross-react variably. There are over 30 assays available, and they use over 20 different monoclonal antibody D-dimer antibodies. And each of those antibodies actually targets a different epitope in the FTP fraction. Assays are currently not standardized, so there isn't a universal reference preparation or universal D-dimer standard. Each calibration material is unique to the manufacturer, and it varies from manufacturer to manufacturer. D-dimer assays are not even harmonized. So just like you think of the prothrombin time and the INR, there was actually a publication by Pete Meyer in 2006 in which a multi-center study created an international reference material from various pooled patient plasmas and created like a correction factor or standard D-dimer value. So each of those D-dimer results could be multiplied by the standard D-dimer value, and they actually showed that this method reduces the inter-assay variability. Having said that, this hasn't been adopted either, so D-dimer assays currently are not standardized and they're not harmonized. So the bottom line is that the results that you get are assay specific, and you really shouldn't be interchanging them across thresholds. If your assay says less than 230, then that's what you use as negative positive. If another hospital says less than greater than 500, then that's what you use. There's also multiple reporting units. The DDU, or the D-dimer unit, is approximately half the molecular weight of the fibrinogen equivalent unit. The magnitude of units being reported by each assay is also different. So 500 nanogram per mil is essentially the same as 0.5 milligram per liter mathematically, but it is confusing to clinicians who are used to thinking in terms of 500 and would automatically try to apply that value to their assay. So this is also an issue which results in lack of interchangeability. The challenge with multiple reporting units that has been assessed by multiple studies in the field is that clinicians don't realize that the value is the same, although the number varies. The example that I just gave you, sometimes labs at the request of clinicians are creating mathematical conversions or fudge factors, to make 0.5 look like 500. And then when they are reporting their results in external surveys for accreditation, it leads to high error rates for those labs. Some labs don't adhere to manufacturer recommended units. They don't validate them in-house. And the most astonishing thing is that there are many book chapters and peer-reviewed articles that don't even mention the assay or the units or the diagnostic performance. In terms of the inter-assay variability, this is a study that a fellow and I looked at 140 Ontario laboratories that participate in mandatory accreditation external quality assurance for Ontario labs. And we looked at the variability on 13 negative D-dimer samples that were distributed between 2013 and 2020. And you can see the 4 common assays that are in use in Ontario and the range on the same negative sample. So the minimum value to the maximum value and the variability or the CV in percentage. So you can see that numerically, even on the same negative sample, there's a significant variability. In fact, some of the labs have even called a negative sample positive. And the good news, of course, here was that when each lab looked at their assay qualitatively, non-numerically, neg pos, the agreement between labs was virtually 100%. But numerically, there's a significant variability, so that speaks to the lack of interchangeability as well. Again, when Caroline and I looked at the quantitative D-dimer on positive samples, So this, we looked at an international proficiency program called ECAT, around 600 international labs from 2017 to 2020, using 35 unique D-dimer assays. The majority of participants used the standard 3 or 4 quantitative automated immunoassays. Less than 5% of participants used the gold standard VIDAS assay, which is actually the one that has been used for most of the derivation studies. Interestingly, when we looked at the group value, so on the x-axis here is the thresholds or the cutoffs. So 0.5 is 500. You can see that at the exclusion, at the VTE exclusion threshold, the variability between assays ranges from 5% to 40%. So the VIDAS is down here, less than, close to 5% inter-assay variability among the labs who use VIDAS. So you could say to yourself, well, I'm only going to use VIDAS, but guess what? It's not really available, and only less than 5% of participants used it. And some of these other popular assays, there's significant variability around the exclusion thresholds. As the D-dimer value goes up, the variability actually reduces. So I've sort of shown to you that they aren't interchangeable, but is that a clinically important difference? So Mark Roger and his group did a very elegant recent study in which they looked at the HER2 true rule, which is the only prospectively validated clinical decision rule that is used in the recurrent VTE setting and reliably identifies low-risk women in the unprovoked VTE group who can safely discontinue anticoagulation. What they did is they had frozen plasma on a subset of these women, and they reanalyzed it, comparing 4 of the commonly used quantitative D-dimer assay with the VIDAS assay, which was used in the derivation of the HER2 rule. And they ended up showing that there was very poor agreement between all of these assays and the VIDAS assay. And it actually led to an unacceptable risk of misclassification of women. Their recommendation based on this reanalysis was you shouldn't use an assay other than VIDAS. The problem again is the less than 5% of labs have access to VIDAS. So you can see that it is a clinically important difference, this lack of interchangeability. So there's lots of implementation challenges on the ground. The assumption that D-dimer assays are interchangeable, failure to adhere to manufacturer recommended cutoffs, confusion between the magnitude of the units and the types of the units. Some labs are still using qualitative or semi-quantitative assays to rule out VTE, and that's an absolute no-no. And finally, something that absolutely needs to change. There's inadequate D-dimer reporting in lots of peer-reviewed literature and textbooks. Often there's no name or type or manufacturer, inadequate reporting of units, analytical performance. And in fact, the ISTH SSE on fibrinolysis in a recent publication raised the alarm on the need for accurate D-dimer reporting in the plethora of COVID-19 publications that we have, in which we don't know enough about the method to even know if it's generalizable to us or to our practice. The problems with all of the clinical decision rules and D-dimer, as Kirsten has so elegantly pointed out in her section, is that when you look at real life studies, decision rules are seldom used in everyday practice, despite the fact that there's very high quality evidence supporting these strategies. Sometimes D-dimer is just done prior to, the patient comes in as part of the Chem 7, the D-dimer, the nurse adds on the D-dimer because there's chest pain, she thinks the ER doctor is probably going to need it. But the knowledge of the D-dimer then biases your clinical probability. We found at Sunnybrook, when we looked at this a few years ago, that even though we adhere to a very strict D-dimer strategy, like a clinical decision rule, well score plus D-dimer, followed by 94%, mandated by the lab, we couldn't find a reduction in radiological test utilization or yield. And so I think it's important to look at your local practice and to see whether your strategy is actually providing, the desired outcome. Finally, Kirsten pointed out about the prevalence of DVT sort of getting lower and lower and the difference between North America and Europe. Is it possible that having an easy blood test is lowering our threshold for who we suspect DVT in, or PE? So when we're thinking about ultrasounds and CTs, there's maybe a level of inertia. The patient has to wait and emerge, they have to have a test. But if you just need a blood test to rule it out, are you going to be more likely to suspect it and just order it and say, okay, if it's a D-dimer, it's negative, then I don't have to worry about the patient. And is that probably lowering the threshold? So these are some of the evidence themes that we need to work on, like thinking about analyzing and improving. So given all of these challenges that Christian and I have laid out, how can we make D-dimer our friend? We have to address this knowledge to action gap on a number of fronts. The first area we have to address is this interchangeability of assays. And international societies like the ISTH-SSC, as well as manufacturers, need to work together to harmonize D-dimer assays, either by some methodology or conversion factors, or stick to one kind of reporting unit so that the calibrators are actually reporting in either FEU or DDU. FEU is more popular. Clinicians are more used to thinking in terms of 500 than 230. So that might be the way to go, but that's something that is urgently needed to kind of fix this mess. Addressing appropriate implementation is something you and I can do at the hospital and local laboratory level. So as lab director, I can make sure that the assay is selected appropriately with clinical input. User education is really critical, and I think that's why we're here. There's a lot of assay heterogeneity that's still not being appreciated by users. They need to understand reporting units, the fact that because they're not interchangeable, you cannot automatically generalize from a management study to your situation if your D-dimer hasn't been used in the study. Use the D-dimer only with a decision rule and use adjusted cutoffs appropriately. Mandatory hospital-based clinical decision support algorithms with performance improvement components have been shown in many clinical settings to improve outcomes. And finally, we need to address real-life effectiveness of these diagnostic strategies. And a good way to do that is still RCTs that look at the real-life impact on selected clinical outcomes, pragmatic clinical outcomes like wait times, like radiological test utilization, and we can do it in a cluster randomized design. So at this point, I'll hand it back over to Kirsten to lead us out.
Thanks so much. So we've heard that one D-dimer assay is not the same as all D-dimer assays. So where does that leave us with age adjusted and clinical probability adjusted and the years? Well, I think the best information we have is the breakdown of assay use for each of these validation studies. We don't have the absolute numbers of patients who were negative by the D-dimer, but we do know the breakdown within the entire study. So what I've done here is totaled up on the right-hand side the number of times each particular D-dimer assay was used in each of the studies. So we know that, for example, the LIA test has been studied probably the most, almost on 4,000 patients, and different adjustments with every one of those 4 studies. Probably the next most studied would be the Innovance. VIDAS too, but of course we don't really use VIDAS here, so it's not generally as useful to us here in Canada. And then we have a few hundred who've been studied with the Hemosil HS500 and a variety of other less used D-dimer tests. So I hope this table is useful. The first thing we have to do is understand what is the D-dimer assay that we use in our hospital. And if we work in more than one hospital, we need to know at each individual hospital. And then the second thing is does that D-dimer assay appear here in this table, which might give us confidence that we can use that adjustment. So to summarize, we hope that in the future you'll consider always using a clinical probability assessment score in combination with D-dimer to rule out pulmonary embolism, to keep reducing the amount of CT scanning that we're doing. Everybody should know their assay, and they should know if their assay has been used in one of these studies before they decide what their approach is going to be for testing for DVT and pulmonary embolism. And in an ideal world, you would already know what you're going to do the next time that you test somebody for either of those conditions. So you've already chosen one strategy, you stick to it, and you use that on a uniform basis. So that will reduce cognitive load, it will standardize what you do, and it helps you become more of an expert. So in summary, we're hoping that all of you will lean into D-dimer. So now we would be very happy to take any questions.
Thank you very much. That was really a tour de force in just reviewing all we know about clinical decision rules and D-dimers. And I have to say, some of the comments are coming in are sort of, are reflecting my personal sort of feelings about it. So maybe I'll start with actually Dr. Jim Duquette's question. So Jim says, I'm feeling rather pessimistic after hearing these excellent presentations. I've given up trying to modify ER physician behaviors at our site. CTPA rates are skyrocketing, essentially replacing clinical prediction rules. And my solution, perhaps low probability for success, is to engage societies and improve education. Do either of you have any comments about that?
Sure.
I think it might be best to start with that.
Yeah, happy to comment. I think there are many barriers to using the Wells score and D-dimer. Education is only a small part of that. Certainly, for example, the Wells score is part of the final exam for all FRCPC residents and College of Family Physician residents who sit the emergency medicine exams. So it's not that they don't know about these scores or that they don't understand the value. So a lot of my work has been focused on how can we introduce an evidence-based approach which fits more easily into the model of care in the emergency department. I think a big barrier to using the Wells score is the problem with cognitive load. So working in the emergency department, it's not uncommon to have 10 or 15 patients who are all being worked up for multiple conditions at the same time. And having a structure in your own head for how you're going to approach each of these patients is important so that you can follow logical, safe testing. And I think that's partly where the difficulty of the Wells score comes in, because there are so many steps to the Wells score. Not only do you have to look it up usually, but each item has a different number of points. Some of the items have more than one separate item embedded within it. You have to understand the definition of each of those things. For example, cancer is a great example. What about the patient who is long-term on letrozole, for example? Do they count as having cancer or not? There are a number of issues that haven't really been resolved there. So it's just a little cumbersome in the emergency. One of the things I've looked at is trying to simplify that approach. And I think the year's approach to clinical probability and D-dimer is attractive for the emergency department because it reduces down the number of points that the physician has to remember, and it's slightly easier to calculate a probability. We're still evaluating the safety, but it looks very promising, and that might be one approach for the future for the emergency department.
Thank you, Kirsten. Rita, do you have anything to add?
No, I think that just one little comment is that, and Kirsten and I have discussed this in the past, and I've discussed it with others as well, is whether a D-dimer first strategy might be a way to go. It's certainly been shown in some older studies. Now, mind you, the D-dimer that was used in those validation studies was VIDUS, but whether a study that sort of validates a D-dimer first approach so that a patient gets D-dimer, and if it's negative, like it's ruled out, minus the CDR, given it might be a simpler approach and something that's more acceptable, just sort of throwing it out there.
I mean, I sort of have similar thoughts myself, and I think as you both have pointed out, when the patient is presenting to the emergency department, it is, we know that many cases, the blood work's already checked off, by the triage nurse, that sort of thing, and or just to get things going, right, because things are busy. So it may be useful this way, but certainly, we need to validate that that approach. And I mean, it would be great if it sounds like if all the D-dimers are so different anyways, that this would be something that each institution should do, right? So this is their D-dimer. If we actually use this approach, D-dimer first, and then actually make decisions about testing or no further testing, and then follow up, that may actually be something more useful and people might use because it's validated, or proven useful in their own setting, perhaps. Maybe I'll go on to other questions. So there's a question actually, something that has come up. So in females who are menstruating, basically does active menstruation actually affect the D-dimer levels, for example? Does that change the cutoff or not?
I mean, physiological stress can increase D-dimer. So for sure, there's lots of biological states that can increase D-dimer, but I don't think that specifically has been validated, like adjusting the threshold based on females or males.
Yeah, and I would say, a younger woman, premenopausal, who's healthy will probably have a baseline lower D-dimer. And so it doesn't really matter if they're menstruating or not. I would still use D-dimer the same way as I would use it for any patient. I would use a standard approach, whichever approach I've just decided is my standard approach, or else a departmental protocol. And I would use the cutoff threshold for D-dimer that you use for all the other patients. Yeah.
Okay, great. Going back to some of the original points you brought up, Kirsten, is about just the differences across the ocean, it seems. All right. So, the difference in the prevalence and positive rates of the radiological imaging. All right. Do you think that has to do with, the clinician's assessment of, DVT and PE? So, in terms whether the way physicians are taught, perhaps even culturally, how and when patients present with signs and symptoms of thrombosis. Maybe in a more stoic population, they'll present very late, so the signs and symptoms are more overt and obvious, whereas in other populations, they show up to emerge with more minor symptoms. Do you think that has an impact on the, the clinical prediction rules in terms of how helpful they are?
I think absolutely. I think you've hit the nail on the head. Here in North America, I think on balance, we probably over-test patients with chest pain, for example, and we may actually under-test patients who present with isolated breathlessness. I think there's a real, the way physicians approach the decision to start testing for pulmonary embolism is very influenced by the culture within an emergency department or within the internal medicine community. I've worked actually in the UK for many years before working in Canada. And I know here in Canada, I see the threshold for testing for pulmonary embolism is so much lower here than it was in the UK. That said, there are no studies looking at the number of patients who have pulmonary embolism missed in Europe compared to North America. So we don't actually know which is the better population of patients to test. So if there was such a study, it could be possible that maybe we have fewer missed cases in Canada and more missed cases in Europe. We don't know that. For sure, we know that we are still missing cases here, sadly. And unfortunately, I think that drives the anxiety around testing and this sort of propensity to over-test, because physicians have all heard about tragic cases of people who've died because nobody thought to test for them for pulmonary embolism. It's a very difficult question to address, and we don't really have enough evidence yet to know who really is the right patient to be tested.
Thank you. Next question about sort of D-dimer testing more. So if a given center uses one of the D-dimer tests used in a validation study, all right, and using a specific clinical prediction rule, right, can we use those adjusted cutoffs, so that age adjusted, the clinical pre-probability adjusted, rather than the manufacturer's posted D-dimer? Because it sounds like both of those sort of aspects were covered in your talk. So again, just for some clarification.
Yeah, so absolutely, you can use age-adjusted or clinical adjusted thresholds.
Instead of the manufacturers.
Yeah, so I'll just sort of explain what happens, how that gets posted on the report, what happens in the lab before that gets posted on the report. So when the lab validates an assay, we are required to show that that cutoff, let's say it's 500 FEU micrograms per liter, we're supposed to verify that cutoff in-house. So what we do is, if we're setting the assay into place for the first time, we will get like 120 normal samples, 60 males, 60 females, and we will verify that 120 normal people have D-dimer values below 500. So that's all we're required to do, is verify what the manufacturer has validated. And that's what we post as the exclusion threshold. The laboratory doesn't have the resources to be able to verify the threshold in our population for every 10-year decile, right? So what clinicians have to understand is the laboratory is never going to post that on the report, because to satisfy accreditation, we have to verify what we post. And we're clinical service labs. We don't have the ability to do management studies every time we publish a threshold, right? So once we've verified it, we've published it, it's up to you, the clinician, to then empirically multiply it by age or clinical probability or do what you do. So, you know, when I'm approached by clinicians to say, why don't you publish that in your report? Absolutely, I cannot do that. So they just have to understand that we are going to report what we verified on the report, and using clinical thresholds like age adjusted or clinical probability adjusted is on them.
And I would say, you know, there is a lot of anxiety around, you know, can I use one of these adjusted thresholds over another? But really the much more important thing to do is to use D-dimer. So I think there's way too much anxiety about the very, very, very unlikely event of having a false negative test, which is vanishingly rare. It's actually much more likely we either don't test at all, the person who has pulmonary embolism, or we don't use D-dimer. So any of these adjusted rules is a step above or a step better compared to either not using D-dimer or not thinking to test.
Along that then, in terms of using D-dimer testing, what about unusual sites of thrombosis? So we're not talking about DVT and PE, but say cerebral sinus thrombosis, which is now a very popular topic, splanchnic vein thrombosis, you know, what about those sites? You know, are you aware of any studies? Are there likely to be studies? Or, you know, do you think the same D-dimer cutoff would apply?
That's such a great question, and I've been asked that so many times in the last few shifts. And really, we don't have any high quality prospective diagnostic studies to guide us there at all. I tend to always draw D-dimer if I am thinking about the possibility of a blood clot, because in general, it's raised or it's higher in patients who have blood clots, but I don't use the D-dimer to decide on imaging or not to do imaging for unusual site thromboses. I just add that to my armamentarium of information that I have about the patient, which will, in my head, modify my pretest probability, but we don't know about thresholds or cutoffs.
Yeah, there's absolutely nothing. Like when we're using D-dimer in those settings, we're extrapolating from DVT-PE studies, absolutely.
Okay, all right. So Kirsten, so you have just said you're using, you know, all of that information in your head, right? So are you following a specific clinical prediction score? Are you using years? Are you using, you know, adjust PE? Like which one are you using?
That's a good question too. So we actually introduced in Hamilton a year and a half ago a process whereby the physician orders a D-dimer, and if it's over 500, then automatically the patient goes for scanning. And if it's under 500, the patient is flagged for review and the physician is told that they don't have pulmonary embolism. That's a very different approach, and we're just at the tail end of evaluating that for safety and an impact on imaging ordering. So it's just to say that's still, you know, under evaluation, but that's had actually a big change in my practice. And very often I'm comfortable just using the standard cutoff because, you know, I'm trying to reduce my cognitive load on my shift. I'm always juggling patients. I want to see patients and see them safely. I don't want to mess up. So actually, more often than not, I just use the standard cutoff. It doesn't mean to say that it's unsafe to use a different cutoff, but all the other cutoffs require additional steps. And I'm trying to make my life easier.
Right. So now, can I just then follow up? So that D-dimer, I mean, most of them are not high sensitive D-dimers and that we're talking about. I know VDAS is, but would you be comfortable using a non-high sensitive D-dimer to do that approach, that in terms of if it's negative, whatever your lab tells you, you're just not going to do further testing?
So just to reiterate, we don't have a ton of data yet, and we're still evaluating that. But so the data, really the only data in existence that we have is through the years study, because in years, if you score 500 or less, regardless of your clinical probability, you don't get scanned. So if your D-dimer is 500 or less, or probably 499 or less. And they had, out of, I think on one of the slides there, I had about 330 patients who were in the higher probability category because they had one or more of those year's items, and they had a D-dimer of 500 or less, and they had 3 patients who were subsequently diagnosed with pulmonary embolism in the following 90 days. So that is 3 out of 330 in the higher probability patients. All of those patients had a CT scan against protocol. So if they had followed the protocol, we don't know if those pulmonary embolism would have been clinically significant or not. We don't know what the clinical outcome would have been. So just to say that, and also, of course, they used all those different assays in that study. The LIA test has been well evaluated and actually has a very high sensitivity. Same with Innovance. So I don't feel uncomfortable about using those assays from their sensitivity aspect. If you want to be conservative and careful, then you would only use a D-dimer to rule out pulmonary embolism with a well score of 4 points or less. And that is what has been very carefully validated across the world, and we can rely on completely.
So I just wanted to clarify the meaning of high sensitivity. The vast majority of assays that are currently in use worldwide are high sensitivity assays. And because the major 3 coagulation platforms are Stago, IL, and Siemens, the top assays are still those 3. And they have a reasonable good performance. They've all had management studies to set their exclusion thresholds. However, the D-dimer first strategy, the original derivation study was done using VIDAS, which is still has the highest sensitivity of all of the high sensitivity assays. The only problem is that because VIDAS is an ELISA assay, people have sort of moved away because labs can't afford to have like a 4-hour turnaround time, for a single test. So as Kirsten says, the year study and some of the recent diagnostic management studies have used 3 or 4 of these popular, commonly used assays. If your lab uses an assay that's not in those studies, I personally would worry because they are not interchangeable.
Okay, all right.
And sorry, just one other last point there. It's interesting that I think 2 of the false negative patients in the year study were VIDAS D-dimer measurements.
Yeah, so I think that that leads to another question I have, but before I go to that one, I'm really interested. So Kirsten, totally I can understand the volume, like you said, the cognitive burden on emerge physicians. I don't know how you guys do it, but just so we could sort of tease this out. So do you have a sense that the clinical prediction rules in thrombosis are any more difficult to apply? Is this the only area where we have clinical prediction rules, and that there are other areas that emerge docs have adopted and have had no problems? So it's something that we need to sort out in VTE, sort of, right? And as opposed to just in general, emerge physicians are too overloaded to use any kind of clinical prediction rule.
It's a very insightful comment. Yeah. So there are a number of clinical prediction rules that have been developed by emergency physicians, and they fit the model a little bit better. And actually, interestingly, one of those is actually the PERC rule, which was designed by Jeff Klein in the States. And the PERC rule is designed to apply to someone who you think, oh, I don't really think they have pulmonary embolism at all. Do I really need to test at all? And we found in our studies that Canadian emergency physicians use PERC a lot. It still has a number of items to remember, but I think the reward is when it's negative, you've ruled out PE and you stop right there.
Yeah.
And I think a lot of people find it frustrating that if you use Wells or even Geneva or whatever your clinical probability scoring tool is, that all that does is tell you should you order D-dimer or not.
Yeah.
And then the D-dimer might not be the end. It might be higher than your threshold cutoff, in which case you then need to order the CT. So some people find that a little more frustrating. Another good example is head injury. We have a head injury rule to tell us should we do a CT scan or can we just send the patient home without a scan. And it's used a lot, and also for the same reasons, because you perform the rule. If it's negative, you stop, the job's done, and you walk away.
All right, that's great. So it's 10:01. I just want to thank both of you. It's been an amazing, really informative session, certainly for me, like in Vancouver, where, you know, I'm not involved in diagnosing thrombosis anymore. Very different than when I was at McMaster, where we saw every single patient who had, you know, shortness of breath or swollen legs. I can certainly understand, like there's a vast difference in culture in terms of actually even approaching, you know, thrombosis. So I think, again, we've all learned a lot from today's discussions and your outstanding talks. Thank you very, very much. I want to thank everybody for attending today. As I said earlier, this is our last seminar for the year. So I want to wish everybody a fantastic summer. Hopefully, you know, when we resume in September, you know, things will be more normal. But I have to say, this has been a really great platform for us to be able to really host some amazing speakers, really broaden out topics, and we've had really great discussions and really great participation throughout. So thank you very much. And again, stay safe, everyone. Hopefully you'll have a great summer that we can all enjoy barbecuing and spending time with our friends again. And stay safe. Don't forget to you know, complete your evaluations. And again, we welcome feedback anytime about our seminars and any topics that you'd like to cover if you haven't heard any, and obviously speakers that you would like to see us host. So thank you again, everyone.
Okay.
Bye-bye.
Thank you.